Hello again, it's Dr. Peter Copp from GP Plus. This is Sunday, the 12th of April. This is the third, hopefully even shorter video, and really I will just call other important matters. Firstly, as I did mention towards the end of the second, the future is uncertain at this time in terms of when and how to relax the social restrictions that we have in place. By and large, people are adhering to these guidelines, and particularly that is the case in the more rural environments. There are obviously examples of the police getting involved in London, but then the population density sometimes just makes that very difficult. We're, I think, a bit more fortunate in Scotland, and certainly the infection density is less, and certainly looking around my local community here in Peebles and in Edinburgh where I work, I think that people have respected the guidance extremely well, but they can only manage for so long, and we need an exit strategy. And that strategy will be underpinned by a number of critical factors. And that again goes back to the World Health Organization mantra of test, test, test. There are logistical reasons why testing is problematic. It is not a government issue. This is about global shortages of key reagents and allowing us to test the people. We can do as many swabs as we want, but we need the reagents to do the test. We also need to make a decision about antibody testing quickly, because there are good serological kits out there as far as I am concerned, but it will need to meet the government's own criteria. But fear of getting something wrong should not be an excuse for inaction. But we do need to be able to relax the social restrictions, and it's very likely that that will not happen in a dramatic way. It will probably be sector by sector, probably not even based on age, but there will be a shifting towards a more normal society, but it will be done it will have to be done in a very careful way, depending upon how much testing is available, but it must be underpinned by that. Countries that have tested aggressively, currently the Americans are testing enormous numbers, so a lot of the resources that are available are in that direction. Germany have done very well with aggressive testing. They ramped up very quickly, and they benefit from having that denominator. The problem in the UK is that we can only really try and guesstimate how much COVID there is just by looking at the number of deaths and then expanding out that pyramid to make a guess, if you like, of what what the actual bowl of infection looks like. Other countries, because of aggressive testing, do know what the whole triangle looks like, and it's much easier to manage policy on that basis. There have been some interesting reports about Finland. Obviously, it's a much smaller country, and they have some limited resources in terms of ICU, but what they have found is a very, very low death rate in relation to the population numbers, and they have tested reasonably well. And there are some theories about the use of saunas and this hot-cold immersion, and that goes back to my first video about the personal observation that the immune response of the host is so critical as to whether this is just a simple self-limiting illness within a week, or whether you move on to this, if you like, viral-induced pneumonitis in week 2. A proportion of those people, and particularly the more elderly and those with other conditions, are much more likely then to need ventilation if they're not coping. And then, unfortunately, that's not great news, because you have an even Stevens chance of recovering. So there is evidence that cold-hot immersion stimulates our killer cell immunity, our T cells, and I've mentioned before that the last time I felt so impotent in medicine was when I was a young doctor and HIV was posing such a challenge and feeling useless and seeing people dying and being unable to do anything about it. Now, because of a vast amount of research and effort and money that's gone into HIV, we now have a very different proposition. It's an illness that can be managed, it isn't without its difficulties, but we now understand much more about the immune system in relation to HIV. And I think we're going to learn something even more about immune systems as a result of COVID-19. And it may well be that it's about subsets of killer cells, natural killer cells, T lymphocytes that vary between individuals that make them susceptible to this impaired immune response in week 2. So whether it's cold, hot immersion therapy or a whole number of other measures that I'm going to come on to in the meantime, having a good immune system appears to be a very important factor. I did mention before this particular article in this week's BMJ, Editor's Choice, and really it is very sad to see that leads, but it's a very important point to make. But my concern is this whole COVID issue is becoming more and more political, but it's very, very important that NHS staff are not just given the PPE they require, but the training and the support to take it, put it on, take it off safely. And some of the PPE that I have seen given to NHS GPs, to me, seem frankly absurd. And individuals have gone off to places like Screwfix and Toolstation to buy equipment that they felt was better suited for purpose, and that really shouldn't happen. Okay, I'd like to draw your attention to, which I think is a fantastic piece of work by a chap called Paul Merrick, who's the Chief of Pulmonary and Critical Care Medicine in the Eastern Virginia Medical School, EVMS. Now, this was brought to my attention in the MedCram series, which I have been watching avidly and mentioned in my first bulletin 2 weeks ago, and I know that many of my own patients have looked at these. Some of them are very, very technical, but they do pull together a lot of different experiences from Italy, from Spain, from China, and in the United States themselves, and explain some of the underlying principles in this epidemic. Now, he goes on to point out that ventilation is not good news, and that their efforts are about this, if you like, golden window of opportunity. Those people who are not getting better at the end of the first week, who move on to this, if you like, week 2 pneumonitis. And obviously some of these people then around day 12, 13, 14 will require mechanical ventilation, and their odds are not great, especially if you are older, if you have comorbid conditions, if you have a pot belly, and so on and so forth, and if you are diabetic. Now, he has, on page 2, made some suggestions towards prophylaxis and treatment of COVID-19, and I'm delighted that he echoes most of the things that I have previously been talking about. In many ways, I feel a bit blessed. I don't have I don't have the limitations placed upon myself that my NHS colleagues do. For the last 20 odd years, I've had time to think carefully and deeply about mechanisms of illness, and I've been in a privileged position to do that, and if you like, many people have paid me to do so, and I'm not any better than anyone else, but I've had the chance to think and reflect deeply on what the mechanisms may be in a particular set of circumstances. And there's stuff here that I've been promulgating all the way along: zinc, melatonin, the importance of sleep, vitamin D. Vitamin D is something I've been banging on around for 15 years, probably annoying people at times. But he has added a very important suggestion, and it's something that they are giving in hospital, is a plant-based compound called quercetin. Now that is a flavonoid. Flavonoids are the pigments in leafy vegetables, but there are certain foodstuffs in which they're particularly concentrated. So things like broccoli, green tea, which is interesting. Buckwheat tea is particularly rich in quercetin. I went online this morning and I noted that certainly Nutrilink, who I buy a lot of products from, recommend they're on back orders for quercetin, so I suspect the news is out there, but I was able to order it quite easily from other suppliers. And I'm not going to take that myself. I've had COVID-19, but I may make it available to my partner, to a member of family, or to a patient if they can't get hold of it. Anyway, it is a plant-based product. It is very, very safe. It can have side effects if given in huge doses, sometimes certainly cause headaches, but really it's an antioxidant. And along with these other components may, if you like, support the immune system in a more favourable way, so that by day 6, 7, 8, things are calming down and going back to normal, instead of those patients who then develop this, over or hyperactive inflammatory response. And I think in time we are going to see that it's an immune defect that allows that to happen. It's not the virus itself. This is a host response to the virus, a host vulnerability. So certainly do look at this article. I'll put a link on at the end. I cannot say that it is the be-all and end-all font of knowledge, but I totally support the observations of this very senior and esteemed clinician. I certainly think people should think about melatonin. It can be difficult to get hold of in the UK without prescription, which is a farce because you can buy it readily over the counter just about anywhere else in the world, and people do in Spain, United States, so on and so forth. But if individuals are having problems getting access to a supply, I would certainly be able to be of some help to those patients at GP Plus. And certainly having a good sleep in itself is important for immune system function. Okay, a couple of other things he goes on to mention. I've already suggested to some patients that just in the way that I use, and probably will just continue to use, because I've had far fewer colds, Sterimar hypertonic saline nasal spray, we could theorise that in the first day or two of illness that perhaps even nebulized saline, which is readily available, sterile seawater if you like, might have some benefit. I spoke to a respiratory professor locally about it, and his concern, understandably, was that if people were nebulizing at home with saline in the first day or two of illness to try and suppress viral load, that they would aerosolize more virus in the house and make it more likely other people could get infected. So my only practical suggestion is either not to do it or to do it outside. And I had contemplated certainly running an extension cord and nebulizing some saline and sitting in the garden. That isn't always available to people living in the city, of course. But certainly Dr. Merrick points out that rather than nebulizing, you could certainly use a spacer chamber, which many asthmatics have access to, and that may be a way to more safely deliver saline. Anyway, he does go on to mention some of the other issues in relation to the actual hospitalized patients. But very importantly, and this means something to me personally, is that he again points out on page 3 that an optional treatment is using this antibiotic called azithromycin. Now, azithromycin doesn't work as an antibiotic in this setting. It is not an antiviral, but it has known immunomodulatory effects via interruption or interference with what are called cytokines, which are responsible for inflammation. Now, there is compelling proof that azithromycin works in people with an underlying condition called bronchiectasis, who've got damaged areas in their lungs, often from childhood infections, but there are a number of other causes. And as I've mentioned in my personal observations, I, on the back of that and my own experience with azithromycin, have used this drug around the day 8 when the patient is getting worse. And although I have only a small number of people to report back on to date, I have been simply overwhelmed with the response. So it'll be a case of watch this space, and I'm happy to report back in due course. But do remember, azithromycin isn't good for everyone. It would be useless giving it to everybody in the population. Some people are vulnerable because of having a long QT interval on their ECG, and it can precipitate a cardiac arrhythmia. So it's not a drug just to give to everyone. I think we're looking at giving it to those people who are not getting better at the end of the first week, and to try and ameliorate what the Americans call the cytokine storm, which certainly I have seen now at first hand. Okay, so I'll put a link to his article at the end. Oh, by the way, for those taking statins, he also makes reference to the fact that they are known to be anti-inflammatory, and he does actually make reference to using high-dose statins in those patients as well. But I think it's a highly inventive piece of work. I applaud him because we don't have time to wait for randomized double-blind controlled studies. We need to use our clinical imagination, and he has certainly done so in this particular article. So I say thank you to Paul Marek. Finally, just to say that again, the last time I felt so useless was in the face of HIV. I graduated in 1984, and at that time, I mean, as a medical student, I was being told all sorts of theories as to why men were dying in San Francisco, and it might be to do with amyl nitrate affecting the immune system, and of course, it was just ludicrous. But at that time, we just did not know, and at this time, we just don't know enough, and we're faced with new challenges. But I think what we will see coming out of this in the long term is, I feel like, a rebooted and refreshed understanding of the innate immune system, and why some people are much more vulnerable to external agents like COVID-19, whereas others are absolutely fine. And by identifying these vulnerabilities, whether they lie in the natural killer cell subset or in some other mechanism, that I am sure we will identify options for intervention so that those people can be, if you like, protected against viral threats of this nature in the future. So despite all of the uncertainties and difficulties and challenges, and boy, we have plenty of them, I think there is hope for the future. We will probably learn an awful lot more in the coming year or two, and I look forward to being able to apply that in my normal day-to-day clinical practice. Thank you very much for listening to me, and that's the last of my 3 bulletins for today. I wish you a good weekend.